So welcome everyone. Thank you for joining today's webinar, BPD and Stigma, Life Beyond the Label, presented by Dr. Amanda A. Ulizik and Amanda Amisoy. I'm Alicia and I'll be moderating today's event with Shuan. We'll be monitoring the chat and the Q&A box. So before we begin, I do have a few housekeeping. So first, this event will be recorded and available on our website afterwards. So if you miss anything, you can always check it out later. But don't worry, this is a webinar format, so you will not appear in the video and your audio is automatically muted throughout the entire event. However, you can communicate with us moderators through the chat during the presentation. If you have any questions for our presenters, please type them into the Q&A box located at the bottom of the Zoom control panel. Closed captioning is available. To turn it on, click on the live transcription icon at the bottom of your screen and select your preference. The presentation will be around 45, 30 minutes, followed by a 10 to 15 minute Q&A. We'll try to get to as many questions as we can. If we don't get to your questions, please email us at programs@abmf.charity and we'll be sure to get back to you. We will be sending a link to the recording as soon as it's available after the webinar. You can also go to our YouTube channel to access past webinar recordings. Before moving forward, I would like to say a few words about the Ashley Boca Mindfulness Foundation and introduce today's speakers. Diane Boca created ABMF to honor the life of her daughter, Ashley Boca, by helping others in their mental health journey. Ashley was diagnosed with borderline personality disorder and lost her battle shortly before her 32nd birthday. Diane does not want others to have the same outcome as Ashley. The Ashley Boca Mindfulness Foundation believes that everyone should have access to the mental health support they need, when, where, and how they need it. We offer support and educational services to those that are struggling with BPD, as well as the broad spectrum of mental illnesses associated with BPD, and for their loved ones. Visit our website at www.abmf.charity to learn more. So our speakers today are Dr. Amanda A. Ulizik and Maya Amisoy. Dr. Amanda Ulizik is an associate professor in the Department of Psychology and the Graduate Department of Psychological Clinical Science at the University of Toronto, as well as the clinician scientist for Sick Kids Center for Community Mental Health and an affiliate scientist at the Center for Addiction and Mental Health. As the director of the STEP, Study and Treatment of Emotional Dysregulation and Personality Pathology lab since 2011, Dr. Ulizik has gained international recognition as an expert in both dialectical behavior therapy and borderline personality disorder, with a specific focus on understanding and improving treatments for adolescents and university students. Her current research more broadly prioritizes psychotherapy mechanisms, outcomes, program improvement, and evaluation, as well as barriers to treatment implementation in a variety of hospital, community, and residential treatment settings. Maya Amisoy received her Bachelor of Arts in Psychology from Ryerson University in 2020. Maya completed her honors thesis under the supervision of Dr. Alexandra Fiocco, in which she examined the moderating role of physical activity in the relationship between acute stress and emotional eating. Maya also has research experience in the areas of sleep and mood disorders, as well as memory and cognition in younger and older adults. Her current research aims to explore the stigma associated with borderline personality disorder and the consequences of such stigma on individual functioning. She is also interested in assessing moderators and mechanisms in psychotherapy. And so that's all that I have for housekeeping and introductions. Dr. Ulizik and Maya, I will pass it off to you.
Okay, so thank you everybody for coming, or everyone that's going to watch this in the future, hopefully. Today, Maya and I are going to present on borderline personality disorder and stigma associated with borderline personality disorder. You've already kind of got a great introduction. Mine was very long. I was a little embarrassed. I wrote it, so there's nothing to be embarrassed about, but I just didn't expect such a warm welcome here. So we're just going to jump right in and start talking about BPD. So Maya is controlling the slides, so I'm just going to kind of cue her. So today, what I always want to do when I'm giving a talk or a webinar is I want you to take a second and think about why you're here right now. So what is the intention? What are you hoping to learn? And what brought you to learning about BPD and stigma? We're going to go through several topics today, and each one just diving in a little bit so you can get a taste of the different issues that come up when we talk about BPD and stigma. So first, I'm going to talk a little bit about what it actually is, a diagnosis of BPD. And maybe you're like, yeah, we always hear that's always the first slide, right? But today we're really going to think about what the symptoms actually mean and how they're associated with stigma. Maya's going to go through what we know about stigma, how stigma develops, and how it's related to BPD. And then I'm going to talk a little bit about how we might start to reduce stigma, little kind of mini interventions. Usually when I do webinars here, we do talk a lot about treatment and dialectical behavior therapy. So I'm going to be talking a little bit about that as well. And then Maya and I are going to discuss some next steps in research that we're doing on BPD and stigma, and hopefully people will be interested and want to be involved. So as Maya goes to the next slide, I want you to take a second and think about, when you think of the phrase borderline personality disorder, what comes up for you? What are those initial words, those judgments that play out, or what are the things that you've heard from people? Now, as a clinician myself, as a clinical psychologist, I've heard lots of words associated with BPD that are unfair and also inaccurate. And we've kind of put those words, how it's associated with BPD often. So we hear things like untreatable, manipulative, attention seeking, dramatic, emotionally unstable. Now, if you're a person living with BPD right now, you may have heard these things from other people. Unfortunately, you may have heard them also to your own self, as a word in your own head. Even today, while I was eating lunch, I was reading a book and a novel, and it came up randomly talking about a crazy person with BPD, using those words in like a random book I'm reading. This is what we are trying to get away from. These are the type of words that people associate with BPD without fully understanding what BPD is. So if Maya, if you move to the next slide, this is how we as mental health professionals actually define BPD. It is a series of 9 symptoms. And so you'll see the different symptoms listed here. They range from behavioral symptoms like, frantic efforts to avoid abandonment, to emotional symptoms like inappropriate or uncontrollable anger, to cognitive symptoms like paranoid ideation. So if you're a person living with BPD, or you're a person who loves someone with BPD or treats someone with BPD, and you're looking at this thinking, well, that doesn't describe me, that doesn't describe the person I know, there's a reason for that. So Maya, if you go to the next slide, what we want to make sure that people understand when we say the word BPD and you're thinking of a BPD diagnosis is that there are these 9 very different symptoms, and you only need to have 5 of those symptoms to get a diagnosis of BPD. So what that means, because there's not one symptom that everyone with BPD has to have, is that there are actually 256 possible combinations of symptoms that could give you a diagnosis, an accurate diagnosis of BPD. So because any combination of 5, any combination of 6, 7, 8, or 9. What this also means is that 2 people with BPD can actually only have one symptom in common and still be called the same thing. Both have a diagnosis of BPD. Now, this is problematic, but this is what a BPD diagnosis is. And that doesn't even relate to things like comorbid other disorders that are co-occurring with BPD, Or what if you only have 4 of the symptoms? What does that mean? It means that there is not one BPD. BPD doesn't look like one thing. And so when we assume people with BPD are one thing, are manipulative, are untreatable, are attention seeking, we're really not speaking accurately to what the diagnosis actually is. So you might think, okay, if there's 256 different ways to have BPD, what is the point of diagnosing it? Well, there's a few reasons why we use a diagnostic label of BPD. So Maya, if you can click the next part. It does give us a common language as practitioners to say, well, this client has BPD. It lets us know a little bit about someone. We might not know which of the 9 symptoms they have, but we might understand that there is often a core of emotion dysregulation, of feeling like your emotions are in control of you and you're not in control of your emotions. That usually gives me that sense, but past that, I don't know much about the client just from that label. It does help us for treatment indications. So many of you know one gold standard treatment for BPD is dialectical behavior therapy. So if I know someone has BPD, I might start thinking, okay, DBT is going to be a good treatment for them. Maybe once I meet them and talk with them and find out more about them, maybe that's not the case, but it can get me kind of thinking about what's a good idea. It also gives us a bit of a shortcut of how things go together. So it's a shorthand kind of metric of how to say what's happening with somebody. And then finally, and Maya will talk a little bit more about this, sometimes if you can label what's going on, that can be really, really helpful. In DBT, we talk about labeling emotions as a way to gain some regulation over them. So sometimes knowing that you have a diagnosis of BPD can actually answer some questions for you. Say, okay, like I'm not alone. Other people are dealing with this. There is some hope for me now that I can put a name to what I'm feeling and doing. Of course, non-judgmental is very important in that because we want to make sure we're using a label as what it is it's just the label. It doesn't mean anything about your future. So again, just to emphasize that BPD is not just this one thing, okay? And that just because you have a label of BPD, it does not mean you look and act exactly like every other person in the population that has that as well. So that's BPD, that's diagnosis. Now, what many mental health practitioners believe is that BPD is one of the most stigmatized mental disorders that someone can have. So Marsha Linehan, the creator of DBT, is quoted as saying it's the most stigmatized disorder. And she is also quoted as telling people, don't tell anybody that you have it, because people will treat you differently. We're going to take a little bit of a different approach with that today because knowledge can be power for people. But we really want to understand more about who is doing the stigmatizing and how we can help. And that's really a big goal for our talk today. So I think Maya's going to talk to us now a little bit about what stigma is, now that we've figured out what BPD is, and tell us a little bit about how this relates to BPD in particular. Go for it, Maya.
Great. So before we really talk about stigma and the association with BPD specifically, I think it's really important that we kind of understand what stigma is and the many forms of stigma that may exist. So just to define stigma, it's the negative attitudes or the discriminatory behavior that are held towards a person based on a specific characteristic or a condition that they may possess. So when thinking about BPD, this could be simply negative attitudes that are held towards somebody based on the fact that they have this BPD diagnosis. So you're discriminating against somebody on the basis that they have a condition. Now, the stigma process and the concept of stigma, it has multiple parts. So there's 4 necessary components that are involved in the process of stigma. This starts with labeling. So when you label somebody with a condition, so for instance, you're saying that this person has BPD, Mary has BPD, you're giving a label. The stigma process then moves forward when we go beyond the label and we begin stereotyping people with that label or that condition. So we may begin to think that everyone with BPD is attention seeking, or we may begin to think that everyone with BPD is manipulative. You're beginning to stereotype somebody on the basis of this condition. This stereotyping then begins to create a division between people. It creates a superior us group and a devalued them group. And this can result in a loss of status within the community as you're really creating a division between people. So for example, just going off of what we've been discussing, it's believing that someone with BPD is attention seeking, but unlike them, people without BPD, we're not attention seeking. So you're really making a divide and creating a divide within society. And finally, the fourth part of the stigma process involves discriminating against someone on the basis of this label. So we see this when you potentially exclude someone from activities simply because they have BPD. So everybody at work is going to the bowling alley, but we're not going to invite the person at work who has a BPD diagnosis. You're discriminating against them simply on the basis of their label. And it's important that we distinguish at this point that all of these parts must be there in order for somebody to be stigmatized. It's not enough to simply say that because you labeled somebody, this is considered stigma. You must have all of the parts together and they must flow in a process in order for it to be considered stigma. Now, beyond what we know about the stigma process, research has also shown us that stigmatization occurs at multiple levels. So firstly, one way that we see stigma present is within the public. So these can be negative attitudes and beliefs that are held by society at large. We also see that stigma can exist at an institutional or a structural level. So this could include institutional policies that intentionally or unintentionally limit opportunities for people with mental illness more generally, or BPD specifically. And then finally, what we do see, unfortunately, also exists is stigma at a provider level. So this could include the negative attitudes and behaviors that are held by healthcare professionals, such as clinicians or general practitioners. Now, what we know currently is that these different forms of stigma can lead to numerous consequences. So in particular, one thing that we see is that stigma has placed limitations on access to treatment. It really has interfered with individuals' ability to go and receive treatment. We see this because sometimes clinicians and other mental health professionals are reluctant to work with patients with BPD because of their own stigma that they hold and because of the stigma that's held at a societal level. So this can be particularly damaging given we already have such limited access to treatment right now, given COVID, and just specifically with BPD, there's less access to DBT and effective other treatments for those with BPD. So already placing further limitations on this because of stigma makes it all the more detrimental. We can also see this in trainees and students in training who are learning to become clinicians. They're going to be, if they hold these stigmatizing beliefs, we see that they're also less likely to pursue work among these populations, which can only further propagate these limitations and interfere with access to treatment. Now, in relation to this point, the stigma associated with BPD can also increase the risk of clinicians providing misdiagnoses. So what we see is that sometimes if you hold a lot of stigma and you're reluctant to work with these populations, you're not really gaining the understanding of the symptoms that comprise the disorder, and you may misunderstand and misdiagnose, and you're not really fully providing accuracy. So this can be, as what was discussed earlier a little bit, it was touched on a little bit, is that this can, if you do not provide an accurate diagnosis of your symptoms, this can be particularly detrimental to your self-identity, and you're not really understanding what it is you're experiencing. So if you're given some other diagnosis that's not BPD when the symptoms that you have are BPD, how are you going to know what treatment's going to be effective for you? How are you going to be able to discuss the symptoms and feel confident if you're really not having an understanding of what's taking place? We also see in the BPD and stigma literature in the past, what was more frequent over the past decade is that there was a debate with regards to whether or not refraining to provide a diagnosis is what should take place. So a lot of clinicians were reluctant to actually give somebody a diagnosis of BPD because of the stigma that's associated with it. So they knew that if they provided this diagnosis, this individual would be highly stigmatized, and they didn't want to do that. So there's research suggesting that, again, this is what was more frequent a little while ago, but that clinicians were actually withholding a diagnosis as a result of this stigma. Now, we also see that there are increased rates of unemployment as a result of this stigma. And another consequence we see is social isolation. So this, again, this doesn't occur on the level of the individual with BPD withdrawing from society, which we'll talk about a little later, but this is society actually isolating this individual because of their stigmatizing beliefs and creating a divide, which we mentioned earlier. And finally, this stigma can also place limitations on normalcy. So just in relation to the point of unemployment, if you're unable to find a job, you're not going to be able to live your life normal and function within society. So considering all of these consequences, what recent research actually shows us is that when you do give a BPD diagnosis and attach that to symptoms in studies where participants read a descriptor of some symptoms, and it actually says that this is because this person has BPD, there's actually less stigma than when you withhold a diagnosis and just provide the symptoms without any explanation. So recent research is actually telling us that when you give a diagnosis, it may actually attenuate the stigma that's associated with the symptoms. And we also see that beyond this, negative emotional responses that are associated with stigma, such as anger and desire to social distance from somebody with a BPD diagnosis, are actually at reduced levels when you provide this label. So we see that there's less stigma and less negative emotional responses when a label is provided. Obviously, more research is needed, but this is really relevant to our conversation today about whether providing a label and having a label of BPD is going to be helpful and effective. Now, beyond those consequences of public and institutional stigma, provider stigma, and what they can do to an individual with BPD, these forms of stigma can also lead those with BPD to experience self-stigma. So self-stigma is the internalization of stigmatizing attitudes that others hold about a group that one belongs to. And these can cause an individual to feel badly about themselves. So for instance, thinking back to all those descriptors that we had at the beginning of the webinar, if you're constantly told that your actions are manipulative and you're always trying to gain attention and you're always angry and acting out of control, you're going to really start to think, maybe I am acting manipulative. Maybe my actions are attention seeking. It becomes a self-fulfilling prophecy, and you start to internalize the stigma that's held and consistently told about you, and you start to feel badly about yourself and believe it. What's really important to understand at this point is that self-stigma is not the fault of the individual, and it's not a result of the diagnosis. So just because you're given a diagnosis of BPD doesn't mean you're going to experience self-stigma. Self-stigma is really stemmed from society. It's really caused by the public stigma that is held within other individuals. And really, if there was no stigma at those at a public, institutional, or a provider level, it wouldn't exist at the level of the self. Now, just as we went over the other forms of stigma and the consequences that are associated with those the stigma at those levels, self-stigma can also have specific and unique consequences as well. So what research has shown us is that self-stigma is associated with negative emotions, such as increased levels of shame of having and living with this diagnosis, heightened levels of distress, which can be particularly damaging given these individuals are already at heightened levels of distress, so it only further worsens these symptoms, as well as We see that there's an increased risk of fear of disclosing your diagnosis, which can be detrimental to interpersonal relationships. So if you feel like there's so much stigma in society and I'm internalizing this stigma, and you know what, now I'm really fearful to tell my friends about my diagnosis or tell my family that I was given this diagnosis, or even it can interfere with your desire to seek treatment. If you're feeling fearful of telling somebody about your diagnosis or going to a clinician's office because you have BPD and having others find out about this can be particularly damaging. As well as we see it can increase social withdrawal. So as I mentioned earlier, those other levels of stigma can create social isolation on the fact of being isolated by society. But these individuals can withdraw from society as well when they're experiencing heightened levels of self-stigma, which can really just damage the ability to live normally and ability to function and just live your life. Now, we also see that there are decreases in levels of self-esteem, self-efficacy to achieve certain goals. So this can be particularly damaging if someone doesn't really feel like their ability to practice the skills that they're taught in DBT, or that they don't really feel like they're ever going to be able to overcome this disorder or recover from this disorder exists, then this may be particularly damaging to them, and it can really limit the effectiveness of treatment. We also see that it can lead to decreases in global functioning. As I mentioned earlier, this can kind of go hand in hand with some of the other consequences of stigma, and as well just overall quality of life can be limited when individuals have heightened levels of self-stigma. And these are all specific consequences that we've seen in the literature that are associated with self-stigma in people with BPD. And what all of these negative emotions can lead to in individuals with BPD is that they can attempt to suppress the distress that they're experiencing. And this can really lead to self-invalidating thoughts and behaviors, which can typically result in further emotion dysregulation, dysregulated thinking, and out of control behavior, which can just create a further cycle of stigma and even worsening of symptoms. I'm going to turn it back to Dr. Ulyzik, who's going to discuss how we can really reduce and respond to these stigmas.
Thanks, Maya. So, like Maya said, we might be experiencing stigma kind of from all angles. So a person with BPD might be getting it from reading a book and seeing BPD kind of referenced in a negative way, to their family or friends kind of not inviting them to certain things, or pulling away, or being scared to engage because they have this BPD label, to actually within themselves or practitioners having certain stereotypes about clients with BPD and not wanting to treat them. So really we have it kind of coming at us from all different ways. So what can we do to now reduce or respond to BPD stigma in particular? And this is not something that a lot of people have thought about or talked about. So that's what we're going to kind of do today a little bit towards the end of this webinar. So the questions that we're going to answer today in talking about what can I do is, who should I tell? So if I'm a person with BPD, when should I tell somebody and how should I do it? And is it a good idea for me to tell? Maya referenced some research that actually shows it might be beneficial, right? It can help explain things for people, and they're more compassionate when they can link a symptom to an actual diagnosis. So we'll talk about that. So secondly, how do I advocate for those with BPD? So maybe I don't have BPD myself, but I have a loved one who does, and I really want to be able to have some advocacy and stand up for people with BPD. The third is for someone also, practitioners or family members, how do I check in with my own stigmatizing beliefs? I love someone with BPD, or I treat someone with BPD, but I maybe am holding on to some negative stereotypes as well. And so how do I release that? And then fourth, how do I fight self-stigma? So again, wrapping it back up to the person with BPD, if I'm having these negative beliefs about myself, or I'm having high levels of shame and fear, how do I deal with self-stigma. And we're going to kind of briefly go through each of these, and I'll give little bits of references to if you want to dive into one of these topics more, of where you can find it. And, you know, spoiler, a lot of them relate to DBT skills, which there are other webinars on as well. So yeah, go ahead, Maya. Maya's like, okay, next one, let's go. Okay, so I'm going now. And my cat distracted me just now. Okay, so who should I tell? That's our first kind of step. First, you get a BPD diagnosis. So we didn't talk too much about that. I feel like that could be like a whole other webinar, because BPD, as Maya said, can be misdiagnosed. So some people may think they have BPD, but actually they don't, vice versa. It's often misdiagnosed with bipolar disorder. They're two very different things. But let's say if you're self-identifying and saying, I have BPD, and that's something that rings true to me when I look at those 9 symptoms, and I want to, you know, this is something I'm owning, it's part of my identity, then you might be thinking, I really want to tell people. What I really want to encourage you to do is, first, before you tell anybody, is you identify your urge to tell by looking at what your interpersonal goal is in telling someone, okay? So have BPD, identify your urge or your goal, and then how to be effective to tell once you decide that it is a good idea to tell, okay? So if we go to the next slide, Maya, I'm going to give a little rehash of how do you identify an interpersonal goal. So if I have the urge to go ahead and disclose this information, I want to kind of take a step back and I want to check in with why I have this urge. So first, is there an objective that I want? Do I need something from somebody, or do I want to say no to someone that has asked me to do something? So for example, you would like access to a quiet space at work to practice mindfulness, because that's part of your mental health journey for your treatment for BPD. And so you want to ask your boss about getting that kind of accommodation. That's an example, right? So that would be, I have an objective, I want to get it met, okay? Good. Maybe you have a relationship goal. And so if it's a relationship goal, that means you're wanting the other person to like you. You're really concerned with the other person's view of you. And that's why you're having an urge to disclose. So perhaps you're in a good relationship, you're wanting to share more about past. That's a time you feel like you want to tell somebody that you have BPD. That's also a very reasonable goal and a good reason to tell somebody. The last one is what we would consider in DBT a self-respect goal. Okay, so in that case, you don't actually want anything, like in the first example. You don't actually care necessarily if the person likes you or don't, like that's not the purpose of the disclosure. But the disclosure is that you feel good about yourself at the end of the conversation. So this is, you know, for sometimes it happens if you're in a conversation and someone says something negative about someone you like, or maybe they share an opinion that you don't share, and you're kind of weighing like, do I disagree? Do I want to do that? I might feel a little off if I can't share my full feelings. I won't feel like I'm standing up for myself. That's a self-respect goal. So maybe you hear a friend referring to an ex-partner as completely borderline in a negative way, and you get that feeling inside that's like, that's not right. And I won't feel good about myself unless I approach that person and say something about what they said. And I'm going to tell them that I have borderline personality disorder, and that's why I want to disclose right now. So these are the goals that we learn in DBT about when is a good idea for disclosing something, of saying something in particular. Now, if you go to the next slide, Maya, once you identify that you have one of these goals, right? Okay, I need something, I'm pulling a relationship closer, or I'm standing up for myself. If you've identified one of those urges, then you have to think about, okay, now how do I best communicate? And in DBT, we talk about how are we effective? So how do we get the goal met, right? So If you want the relationship to draw closer, well, there's going to be strategies that how you talk about BPD that will achieve that goal. There's going to be strategies that don't. So that's what effective communication means. So first, you want to think about when is an appropriate time to share. It might not be the very second the urge comes into your mind, right? It might not be the very second that you've decided this is an important objective for me. You really want to make sure there is time so you can have a conversation. You want to consider your privacy and the privacy of the person you're telling. You want to make sure that person's in a mood that's receptive. So are they willing, is it the end of a very long day and they're exhausted and it's maybe not the time to jump into a really deep conversation? You really want to be considerate of that because that will increase how effective your message is. So next, you want to make sure you're in wise mind. And so, you know, I talked a little bit about, in terms of BPD, that core of emotion dysregulation. And so that's when our emotions are in the driver's seat. We're just acting completely on emotions and not able to tap into the rational part of our mind. Where in wise mind, we have access to both. And that often involves being mindful. So I can understand my emotions. My emotions aren't bad or wrong, but I can also think about how to be effective at the same time. So if your emotions are running hot, you're at a 10 out of 10, it's probably not the best time to talk about this and to share this, right? We all know when we tend to share at this point, we're not effective communicators. Nobody, it doesn't matter if you have BPD or not, none of us are very effective at communicating when we're a 10 out of 10. Number 3, you want to make sure to ask the person, do you have questions or concerns? Like, let's figure out, do they know what BPD is? Are they thinking manipulative, crazy, self-destructive? Are all these stigma words flashing in their mind? You probably want to ask them, what do you know about BPD? Can I answer questions for you? And yeah, so you want to make sure you're available to answer questions and you can point people to relevant information. And that's the same thing for number 4, right? Is you can acknowledge if they say, oh, no, that's fine, that's great. Oh, you have it? Okay, cool. Yeah, I'm totally cool with it. You can say, hey, I know that this might be something that comes with negative connotations. I get that. I know that this might be hard to hear. I understand. That's a great way to validate someone's mixed emotions that they might be having, right? Remember, we all hold stigma about all sorts of things. No one is fully free of stereotypic thoughts, nobody. And so acknowledging, hey, you might be a little scared right now, or you might be a little worried about me. Do that, validate that piece of them. Make sure that they feel heard as well. And then number 5, if you are familiar with DBT, you know that each of those goals I just talked about has very specific suggestions for how to communicate. So I encourage you to look at the other webinars or to look into DBT interpersonal effectiveness skills more. But there are, you know, they're called Dear Man Give Fast for those of you familiar, but there are ways that that can help you formulate the exact wording for what you might say. Okay, so that's kind of the thinking about who do I tell and how. Next is about how do I advocate for those with BPD. So I had that example in the last one of you hear someone maybe saying something negative about BPD or putting out some misinformation about BPD. Well, I encourage you to think of these kind of 3 different tactics, okay? So, you know, spend more time asking questions than lecturing about it, right? No one likes to be lectured to. I should know, I'm a professor. I lecture to people all the time. No one really likes it all that much. So make sure that you're asking questions. Oh, I just heard you say that people with BPD are crazy. I'm wondering about where that comes from, because that's not something I believe. So you get people talking, have them explain themselves, give them a chance to do so. If you can, then educate them. So you can provide fact-based education, you can correct misinformation. You can share then about your personal experience if you are in Wise Minds and it's an appropriate time for you. And then last, which, the last webinar I did was all about validation, right? We know people are more likely to change if you validate them first. We're pretty sure we know that for most part, right? So if we can say, I get what you're saying. I'm hearing you. I understand that that's been your experience so far. And I want to tell you that I think it's not helpful when you call people with BPD crazy. So I get that you've had some tough experiences, and at the same time, I think it's a good idea maybe to change your language around it. So these are the things you can do to be an advocate, ask questions, educate, validate, and then expect the change to follow or hope that the change to follow. Okay, next we're talking about identifying your own stigma. If you are a practitioner, if you are a person with a family member, friend, or partner with BPD. So Maya had already mentioned that when you treat someone like they are going to fly off the handle at any moment, or that they are attention seeking or manipulative, or that they'll never get better, that's often how they will act. Remember, it's so hard, but remember to not respond only to the version of someone you have in your head. So if you have a version in your head like this person is always this one thing, you start responding to them in that way. And that is really easy to do. And it's also not fair, especially if you have a person in your life with BPD that is trying to make changes, right? So you might be expecting the fragility or expecting the emotion dysregulation, but as they're working towards a life worth living, or even if it's a 1% change, be open and receptive to that change. Don't automatically respond like they're a person that's never going to change. And again, have some compassion. I think we forget, because it can be very difficult and stressful to be a family member, friend, or partner of someone with a mental illness at all, or a physical illness for that matter, can be very stressful. And at the same time, we also want to have compassion for what they're going through, right? That it's a very painful disorder to carry. You can go to the next point, Maya. And for practitioners, remember that BPD does not tell us everything. It is just a shortcut. It is just a diagnosis. People look different with BPD. The labels do not tell us all. We might know a little bit based on the label, but it doesn't tell us what's going on right in front of us at the moment. So make sure that there is not institutional stigma or practitioner related stigma for those with BPD. Because that can happen. Make sure you're asking the client, you're finding about the individuality of that client. And if you're unsure and you're nervous about treating someone with BPD, seek out extra training, seek out a DBT course, watch webinars, do some reading, and the more exposure you get, the more comfortable you feel. You go to the next point, Maya, because this is a Marsha Linehan quote. It can be agony living with BPD at certain times. And so we really want to make sure we have compassion and remember that BPD is treatable. People get better and they feel better. That's really important for us to know. And then finally, self-stigma. If you're having, all self-stigma are negative thoughts about yourself that relate to your BPD diagnosis. They're just thoughts, right? And we know thoughts are not facts, but we react to them like they are. So we want to fight against your self-stigma. 3 C's to help you remember. Actually, these 3 C's will work for other people's stigma too. So if you're stigma about something else, you can use these as well. You want to catch the thought. So you have to first notice that you're having a stigmatizing thought in order to change it, right? We have to radically accept that it exists before we can make the change. So we want to use mindfulness to grab on and notice if they find out I have BPD, they won't want to be my friend. Maybe I'm having that kind of a thought right Next, I want to check the facts, which is an emotion regulation strategy. So I want to say, hey, am I predicting the future with this thought? My thought can't predict the future, right? I can't say they won't want to be my friend. I can't mind read them, right? How do I know? Do I have other friends? Yes, I do. Do people with BPD have friends? Yes. So you have to start going through and checking, is this accurate? And then finally, can you change it? So can you replace it with a more balanced thought? And this is the tactic you'll see if you've ever done cognitive behavior therapy, dialectical behavior therapy. We do a lot of this. Self-stigma changing. So can you catch it? Can you check it? And can you change it? Okay, so at the very last few minutes, really quickly, we're just going to tell you about some research that we're doing in my lab, the STEP lab at U of T, where we are continuing the fight against BPD and stigma. And so really quickly, Maya is going to tell you about how we're trying to understand more about BPD in the community, and how the average typical person thinks about BPD. And I'm going to tell you a little bit about an intervention that we're developing for BPD stigma. So go ahead, Maya.
Yeah, thank you. So just to let you know, as it currently stands, there's very limited research on the general public's perceptions of BPD. There's a lot of research on clinicians' perspectives, and there's some research on self-stigma and within individuals with BPD, but we don't really know what the general public's perceptions are. We know that stigma exists, but we don't really know why, and we don't really know where in the diagnosis it does exist. So what we really want to understand is the stigma that's associated with individual symptoms. So perhaps presenting somebody with symptoms and kind of understanding more of the 9 symptoms that comprise the diagnosis. Where does the most stigma lie? We also really want to explore how diagnostic disclosure can interact with demographic and individual difference variables. So just very briefly, to give you some context, understanding whether if you manipulate the person with BPD and kind of make them a very functioning person who has a full-time job, do they have more or less stigma than somebody who doesn't have a job? And kind of understanding how relationships with people with BPD may also affect the levels of stigma. And really what this is going to tell us is it's going to let us know how we can predict the potential consequences of disclosing a diagnosis in specific social contexts, and really inform how we can understand stigma and best protect ourselves against it.
Great, Maya, thank you. So really quickly, we are also developing an anti-stigma group-based intervention for BPD. This is there's one for psychosis called BOOST, and so we are wanting to adapt this psychosis-based anti-stigma intervention for BPD to help really highlight and target both people with BPD and their family members or friends or significant others, that they, important others, and reducing stigma and self-stigma. Maya, if you can put the next one as a flyer. So what we're doing now, because, for me or Maya to just go in and say, this is what stigma is all about, that's not fair. We really want the content of this group to come from people living with BPD. And so we're right now building an advisory committee of people living with BPD right now. So maybe you have the diagnosis currently, or someone has diagnosed you, and you would be interested in participating in being on our advisory committee. We would love to speak with you to help us actually develop content for this group therapy. You can see, and I think they'll pass around the flyer, that they'll be able to put it on social media. Yes. And so what we're looking for is just a small group of people who can dedicate 2 or 3 hours a week to helping us. You'll be paid. It's a job, like you will be reimbursed for your time. But if you're really interested and motivated to explain your stigmatizing experiences and help us develop skills and tactics and intervention and content for this type of group. That's how the Boost for Psychosis was developed, with people with psychosis, and we want to do the same for BPD and really honor those experiences. So my email, my lab email is in the bottom, and along with my website, if you want to look, and you can contact us through that as well. Or you can just, you can find me somewhere. Not many people have my last name. You just type my last name and you will find my email at U of T, whatever. You can let us know, because we're looking for inquiries. We have a couple people interested now. We're just looking for a small committee. So please let us know if BPD and stigma is something you're interested in talking more about. And that, my friends, is the end. We really thank you for your attention. We really thank you for wanting to think about this important topic and to look inward at what, your own experiences might be. We're really excited. So yeah, that's it. Thank you.
Dr. Ulyzik, Maya, thank you so much for that wonderful presentation. We have about 5 minutes for a quick Q&A. So if you'd like to ask the presenters questions, please put them in the Q&A box at the bottom. If we don't get to your questions today for any reason, you can, or if you think of a question later, you can always email us at programs@abmf.charity, and we'll ask your question to Dr. Ulyzik and Maya, and they'll revert back to you as soon as possible. So I'll give it maybe a minute to see if anybody has any questions, or a few seconds.
I think there's a couple in the regular chat too. A couple questions.
Feel free to email. There have been a couple of comments. One, for example, being that eliminating self-stigma has been very helpful for them. And there is somebody who would like to get involved. So perhaps I will see if maybe I can also distribute it to everybody who registered on Eventbrite/Zoom. I'll try to distribute your flyer right after this. So if nobody has any questions, I suppose we can close the webinar for today. So this has been really, really great. Thank you both so very much for presenting such an important topic. And thank you, everyone, all attendees, for joining us today and participating. And we appreciate you being here. Please remember to follow ABMF on social media and check out our website for future webinars and events. And please also don't forget, if you are interested, to reach out to Dr. Ulyzik and Maya about this, the committee. So if that's all, please everyone be well and stay safe.